Well, hello, everyone, and welcome to tonight's second part of our Geriatrics member interest group on caring for older adults. Tonight, we are focusing on the career paths in caring for older adults. I'm Ginny Flynn, Vice President of Communications and Member Engagement for the Illinois Academy of Family Physicians, and I also staff our member interest groups. So our Geriatrics MIG is open to all members of any stage in your career. You can find it under the membership tab on our website. Just log into your profile and add the e-list to your features. And again, our commitment to equity, diversity, and inclusion. We hope that this activity tonight represents and embodies this statement. Just a couple of reminders. We've all been doing this for 4 years now, but those of you who have joined, just keep your, make sure you're on mute. You are welcome to have your camera on or off, but be aware of what may be going on behind you that you may not want us to see. Feel free to put questions in the chat as you think of them. And sorry, I've kind of blocked my own view of my questions. And then even if we have time, we can have attendees raise their hand and ask their questions live. And a recording and an evaluation will be emailed to all attendees along with some resources that are covered in our event this evening. All right, I have a couple of polls just to see who's here and where you are. So let's get those launched real quick. First is, want to hear about you. How many of us are on the call? And let's see, hopefully you're seeing that. Okay, here it comes. Asking where you are in your medical career. Give them a couple minutes for people to answer. Oh, it says it's failed to launch. I'll try one more time. Failed to launch, that's like a common phrase. Okay, that one didn't work. Let's try a different one. Nope, let's try. If not, we will just skip this. Okay, there it goes. I think it's going to make me go in order. Okay. I'll give it another minute or two. Okay, everyone's answered, so. And here come the results. We're missing the residents. Got some students, got some early career, and some who have been at least 3 years in practice. And let's see if we can get, we're gonna go with one more. About your knowledge of geriatrics, whether it's been through your medical school education, your residency training, or your professional CME, how much do you think has been devoted to adult care? And again, this is kind of a estimation, not so much in years, but in your lives so far. All right, we'll give one more minute. Whoops. And there's the results. Okay. And let's go back to, I'm going to turn it now over to our guest host for this evening. Medical student Emmy Sakigabara is a student at third year at University of Illinois at Chicago and has been a very active participant in the Geriatrics MIG interest group, or the geriatric member interest group, and has not only taken an interest in geriatric care, but has also taken an interest in serving and the role of asking those burning questions that students, residents, and early physicians may want to know about careers. So I'm going to turn it over to her, and she's going to introduce our panel, some of whom you might have seen if you were on part one, and a couple that we have that are new from various career paths who are well known to the IAFP because they've been active with us for a long time and play very significant roles in the Academy. So with that said, I'm going to stop sharing my screen and turn it over to Emmy to take it away.
Thank you, Ginny. Hi, everyone. Like Ginny mentioned, my name is Emmy. I'm a third-year medical student at the University of Illinois College of Medicine in Chicago. And I am starting to think about a career in geriatrics. So I'm very grateful to the IAFP, Jenny, and everyone involved in making this happen. It gives me a great opportunity to ask questions, to learn more about geriatrics, and ask all of our wonderful panel members on how they spend their time caring for patients, what settings in which they care for the older population, and kind of their insights. So without ado, I will introduce our panel members. Our first panel member is Dr. Edberg. She is an experienced family physician and medical educator. She is a founding program director of the McGaw Northwestern Family Medicine Residency Program at Erie Family Health Center in Humboldt Park. She was involved in starting Rush Esperanza, a new family medicine residency program for underserved communities in partnership with Rush University. And she has experience with national advocacy for alternative methods of funding GME programs for community training. So without ado, Dr. Edberg, please introduce yourself also.
Thanks, Emmy. Yes, so up until about 4 years ago, most of my career was based in education, and probably until 10 years ago, I did full spectrum family medicine, including OB and inpatient medicine, and a lot of that was with a residency program. But about 4 years ago, I kind of gave it all up and started working for Oak Street Health. And this past year, I've been with Oak Street. I'm the chief wellness officer there, and Oak Street Health, for folks who aren't familiar, is a value-based care organization. We only take care of Medicare patients. So my primary population is geriatric. And probably unlike many of the folks on the panel, I didn't do a geriatrics fellowship or get special training in geriatrics, but that is my primary patient population right now.
Thank you, Dr. Edberg.
And I want to say that Dr. Valak was my first partner in my very first job at FQHC about 100 years ago. Hi, Jim.
Oh my goodness. So we'll definitely have to ask questions about your experience in that role too. Okay, thank you so much, Dr. Edberg. Our next panel member is Dr. Ranjit. He practices in a variety of settings. He did his fellowship at UCLA in geriatrics, and now he is the assistant professor. He is an assistant professor and director of geriatrics and palliative medicine at the SIU School of Medicine. He serves as a board member of the IAFP Board of Directors, and he is a co-host on the podcast, the Brain Trust Podcast.
Thank you, Amy, for the introductions. I would like to just talk a little bit about myself, I guess. It's hard when you have to talk about yourself. I am currently, I would say, one of the youngest panelists in the group right now. I started my practicing geriatrics about 4 years ago, so slightly over 3 years. I started as a geriatrician in a group of family physicians practicing in FQHC in Southern Illinois University. But I saw a need for geriatrics over here. So I started pushing for programs, and then we ended up creating the division of geriatric and palliative medicine over here. We also created a special clinic for geriatric population over here. It's called the SIU Center for Healthy Aging and Wellness. There was a lot of interest in geriatrics, and things had not been done previously. But we have expanded a lot since. We have 3 geriatricians, 3 nurse practitioners, and a number of multidisciplinary providers in our clinic now, which I feel is I am very proud of, basically, given that it's just been 2 years since we started doing all of this. I also practice as a medical director in one of the nursing homes over here at Lewis Memorial Christian Village. We have collaborations with about 10 assisted living facilities where we provide care for patients there. We also do home visits for patients who cannot come to our clinics. Besides that, I also do a little bit of inpatient medicine as well, a few weeks a year. And I also have a another clinic in Carbondale because it's one of those geriatric deserts where we do not have many geriatrics provider, where I see patients on a consultative basis for about 2 days in a month, basically. It's very exciting. The fact that I can create things as I move and very fulfilling. So I love what I do as of now.
Thank you so much, Dr. Ranjit. Our next panelist is Dr. Mantha. He completed his fellowship in geriatrics at Loyola University Medical Center. He's assistant professor of geriatrics and associate fellowship director for the Loyola Hines Geriatric Fellowship Program. And he is affiliated with the Edward Hines VA Medical Center and does home visits for medically complex homebound veterans. Dr. Mantha.
Hi, thanks, Emmy. It's great to be here. So I'm Avinash Mantha. So just a bit about my background. So I did my FM residency in New York. So I finished up so in 2017, so about 6 years ago, I did a geriatric fellowship at the institution where I'm currently at. So actually most of my practice and my fellowship was at the Edward Hines Veterans Hospital, which does have an affiliation with Loyola Medical Center. And I was in private practice for about 1.5 years, and then I came back to Hines to the VA. And I'm actually in a pretty special program, which I enjoy. So I'm in a program that's called home-based primary care at the VA. So it is doing home visits on our sort of very medically complex homebound veterans, right? So these are our patients who have had strokes, who have advanced dementia, who have advanced Parkinson's disease, end-stage COPD, end-stage CHF, things like that. And we're able to sort of give them, comprehensive care in the home. So it is a team-based model. We have a nurse, we have a pharmacist, we have a dietitian, we have a social worker, physical therapist, psychology, and psychiatry. So it's a whole team. And I really enjoy it because I get to do sort of comprehensive geriatric care in the home, right? So I'm seeing patients walk in their home. I'm assessing for their safety. I have a chance to look at like all their medications like in person, right? So seeing what they're actually taking, and to just like assess how they live. I also do have a weekly continuity clinic, like an outpatient geriatric practice, which is mostly with trainees. So I precept with our geriatric fellows and also with a lot of students and with residents as well, FM residents and also IM residents. And I do some occasional work in our nursing home as well as in the inpatient geriatric unit, and do a lot with our fellowship. So I'm associate director, so I do lecture often and work with our fellows a lot. So.
Thank you, Dr. Mantha. Our next panelist is Dr. James Balick. He serves as the medical director of Vitas Healthcare in South Chicagoland. In his career so far, he has led a large FQHC, opened his own practice, taught many residents and students, and provided leadership in various institutions. He's passionate about treating those who struggle with access to high quality, equitable medical care, and his current focus remains in bringing palliative care principles and practice upstream in primary care.
Thank you, Emmy. I really appreciate that you said in my career so far that leaves me a whole lot of things still to do. I've enjoyed being a family doc. Early part of my career, first 15 years, I delivered babies. And second half of my career, I've morphed towards the end of life. I'm board certified in hospice and palliative medicine. And I, when people ask me why do I keep being called back to hospice, it's because it's fun. And I know that sounds strange, but it is honestly the most impactful I've been able to be in my career. And remember, most geriatric care, most hospice care, most end-of-life care is provided by you guys, by family docs throughout the country. So the more we can teach and talk. We need specialists like ourselves, but the bulk of this is generalists. And so we really appreciate what you guys do. Thanks.
Thank you, Dr. Valley. And our last panelist for me to introduce tonight is Dr. Raj Shah. He is a professor in the Department of Family and Preventive Medicine and the Rush Alzheimer's Disease Center at Rush University Medical Center here in Chicago. Dr. Shah completed his family medicine residency at West Suburban Hospital and Medical Center and his geriatrics fellowship at Rush. And he works actively in academic geriatrics, and his interests include community-based clinical trials for the prevention and treatment of age-related conditions, including but not limited to dementia.
Great. Thank you, Emmy, for the introduction. And yeah, I don't think I would have predicted the entire path I've taken, but I think that's what you learn as time goes on in your career. And it's great to hear the stories of other members as they've shared their excitement about geriatrics and their engagement in this space coming from a family medicine background. So after I finished my fellowship in geriatrics in 2000, and I want to go back on the reason why after like a family medicine residency and that I chose geriatrics was what I started realizing when I was at West Suburban is that if I could interact with the oldest person in a family, usually the grandmother, and I could find a way to develop a relationship with that grandmother and help her and build trust with her, she could affect the health of multiple generations and others in her community. So it came back to some of those principles of how do you influence the most people to improve their health with the limited time you have and skills. And that's what I really found interesting in thinking about going to a geriatrics fellowship again. And in my fellowship, I really enjoyed learning the complexities and the syndromes associated with geriatrics. But I resonated in my first year of practice as a geriatrician at Rush on the faculty in the fellowship program there with being able to have an opportunity to work in the Alzheimer's disease space. And this was again 2001. And it was very clear after starting to work there in a multidisciplinary team with neurologists and psychologists and psychiatrists that we didn't have the best solutions for a very common public health problem, and that we had to work with people to participate and learn from them together in research. So I started out as the medical director of our memory clinic, where we evaluated people coming in for concerns about their memory. And then eventually decided that the way to combine that with an academic career was to build out skills in running clinical trials and being able to test new interventions and options so that we could work together with individuals that volunteered, wanted to do something altruistic and to participate in us finding new answers to questions. And as that grew over time, eventually I transitioned after about 10 years of being the medical director into overseeing our portfolio of clinical research studies with a team at Rush. And that's really been exciting to be involved in how do we design studies to address key questions about dementia, and working through every study giving us a better answer, and hopefully eventually generating some real world treatments that everybody could use to help with the public health needs, not only in the United States, but around the world for Alzheimer's disease. A unique feature of that has been also to be able to add the geriatrics component in it, or I think that dementia is just one piece of the picture, because what's really important to older adults is not just about how long they live, but it's like for each day they live, can they maintain their mobility and maintain their mentation? And if you were part of the first session that we did with other panelists, we talked about the M's, or the kind of the M's of aging, which are really about things such as what matters most. So I'm glad we have Jim on the call today, because it is those discussions about what people want out of their lives. And then it's about mobility and how do we get around and do the things we want to do as we age. That's the second M. The third M is around mentation, and the fourth M is around medications. And then how do we kind of manage those issues? And if we can bring through all of those pieces in something where we've looked at an outcome that had never been studied before called disability-free survival, and looked at whether if you're a healthy senior, if you're in your 70s, in 20,000 seniors and individuals over age 70 that were healthy in the United States and in Australia, over 5 years of follow-up on average, we ended up determining that aspirin didn't really help in maintaining disability-free longevity. But even having that answer was really important because it could affect sort of our guidances about what do we do in older adults in primary care about and being part of a team that helped design that study and then execute it and develop and disseminate those results really was an exciting moment to kind of advance our understanding in geriatrics and to move forward. So really appreciate the opportunity to be part of this great panel and look forward to the continued discussions we have.
Thank you, Dr. Shah. And I know that you are also a co-host on the Brain Trust podcast. Is that correct?
Yeah, no, it's been a great series. We really appreciate the Illinois Department of Public Health and their grant that they provided to the Illinois Academy of Family Physicians to work through, like, how do we get better at in family medicine and primary care around early detection of dementia. And it's been really fun co-hosting this with Dr. Yukesh Ranjit, and we invite guests from all over the state as we go out and meet with them for a 30-minute discussion. And I think we have 30 of them now. So, you know, if everybody wants to go, please use that as a resource to really understand what people are doing in their day-to-day practices to help people that are thinking about memory loss and how to handle it. So it's just a nice little piece you can listen to like before your classes or, you know, on your way, like in a break at lunch or on your way home. So thank you.
Thank you so much. And so now that everyone's been introduced, I would like to kind of kick off a discussion. Anyone in the audience is welcome to drop any questions in the chat they would like to ask. I'll try to keep my eye on the chat, or you can unmute and ask the question yourself. But to kick off the discussion, I personally have some questions. Dr. Valek said that palliative care is fun, and that's sounds like a very rewarding aspect of his career. But I was wondering, and this is a question for all the panelists, what are some of the most rewarding or fulfilling aspects of your career in geriatrics?
You know, I mean, I think, you know, some of what Raj was talking about is really quality of life. And I think for me, I mean, older adults can be super complex in a lot of ways, but really to continue to circle back to that, what matters to you and what's important to you, and helping them navigate that conversation with their family, I think has been really interesting, because a lot of families have a harder time of kind of letting go and walking that final chapter with their family member. Even when the family member sort of expresses, well, I don't want this treatment or that treatment, but I don't want to upset my family, and just helping to give them that voice to advocate for them, even within their own family, has been super rewarding for me. And I find that really enjoyable and something that I value a lot.
I would agree with the other points. I would say, you know, like for me, right? I mean, we all have, of course, you know, very complex patients. So it's oftentimes about these small victories, right? You know, someone has been in the hospital a lot, right? They've been in the hospital like almost like every month, right? And we're able to actually keep them out for some period of time, right? So we can work on their CHF and, you know, and the education and their diet, and they understand about diuretics and to be taking like all their medications, and we can give them like some quality of life, right? So they can actually be out of the hospital and they're actually with their family, right? So it's oftentimes those small victories that actually matter. And so I do find it to be very fulfilling, like along, you know, just with the education piece about helping someone to actually guide someone through like a very complex decision, right? There is like a sense of, satisfaction that actually comes from, hey, look, this was, something very scary, and all of us sort of worked on it together, and we understand it better now, right? And we can actually make an informed decision. That's, I would say, one thing that after I'm done with that conversation, I feel a sense that, I'm actually satisfied, and it feels like it's a rewarding thing to me. So
Uh, I agree with the both of you actually, and one of the things that has been really rewarding for me is whenever I accept a new patient, just because we're geriatricians, we have more time in our clinic. I have much more time to go through the patient's issues in much more detail and get to understand, where the patient is coming from, what the patient has. And in some of the evaluations that we do, like, we ask the patient about like their hearing issues there, if they have tooth, if they have dentures, how do they eat, any issues with vision, and like, if they have a walker, cane, have they fallen down? The patients really appreciate us taking care of all of these aspects of their, living. Also, some of the other things like, assessing their activities of daily living and things that matter the most for the patient. Like, for example, I had a patient who, loved fishing, and he was non-compliant with all of his medications, had congestive heart failure, primarily because he was on Lasix, and, Lasix would prevent him from going fishing because he would have to go pee all the time, basically. So when I had a conversation with the patient and just told the patient that he could just stop taking Lasix on the day that he goes fishing, and then he could continue it the next day, he was compliant with all of his medications thereafter, and he thanked me for improving the quality of his life. And the simple things that make a lot of difference to the patient's life, it's really rewarding.
Yeah, Dr. Runcheat, that's exactly where I go with this too, is it's all about right sizing the amount of healthcare that a patient and family can tolerate, can handle, can wish for. Because boy, we all know the healthcare machine can really take over for people with chronic illness, severe illness. And if we can just get it to the point where it's right sized, we can improve lives.
Yeah, and I think for me, I mean, I've always enjoyed the stories, honestly. I mean, the people you talk with that have been on this earth for, 8 decades, 9 decades, 10 decades, they were just walking history books, honestly, about what it's like and their experiences. And what I found is like a little tip and a tool is, especially because I work mainly in the area of evaluating people with memory loss, is they come with their family member when they meet us, right? And I would always just like start, with the standard, hi, I'm here, that's my name, and we're here. Tell me a little bit about yourself. Where did you grow up? Things like that. And part of that's to help me to understand, like, also how much memory people have about the past, but we just do it conversationally. But the thing that always lights people up is you ask them how they met their partner that's in the room. And just having that discussion of people talk about how like 50 years ago they met their loved one is really like a joy in the day, right? To hear those stories sometimes. I've had the luck also of meeting people at the end of their careers. One of them was the last um, kind of intern that was with Frank Lloyd Wright that was still living. So, just really these incredible people. One of them was the architect of one of our buildings at Rush, 50 years before. So it was just, if you just open yourself up to the humanness of a person in front of you, and and engage with them about their stories, about their lives, you just learn so much. They always teach me more than anything I can teach them back. And that's what's been so exciting about being in geriatrics.
Yeah, I used to live with my grandparents, and I agree. I loved living with my grandparents because they were always so full of stories, and I felt like I learned so much from them. And so, taking the time to really talk to your patients, I can imagine is very very rewarding and very interesting to you also. But I had a question: how do you manage the multi-complexities of your patients? Talk to the families, make sure that everyone's on the same page in such a short clinic visit time? Or is that different depending on whether you're doing a home visit or in the clinic? How do you kind of manage your time with these patients?
So, so I can start. So Oak Street is value-based care. So we have longer visits to begin with, although I think some of the geriatric clinics probably have even longer than we do. But our follow-up visits are 20 minutes, and our initial visits and yearly visits are 40. And we have a pretty extensive team that manages quite a bit of the needs we've got in every clinic. We have scribes. We have an assigned MA, we've got a nurse, we've got community health workers and social workers and behavioral health and people that manage the insurance stuff. So a lot of that stuff that isn't reliant on a physician to do, that in some other types of models that you still end up spending your time trying to navigate for a patient is sort of taken care of by the team. So all the barriers to their care are kind of managed by other people. So I can just sort of sit with the patient and figure out how to manage their complex conditions. And we've got a lot of kind of clinical education support that keep us up to date on things. So a lot of it is sort of done for us. I think that it could be really overwhelming in a model where you don't have a supportive team, I guess.
I would agree with that, actually. One of the biggest factors that we have is the time period that we have to spend with our patients. We actually have 30 and 60 minutes, so we get slightly more time. Creating a structure is another thing. A geriatrics clinic is slightly different than the regular family practice clinic, and we have to create a structure where for our entire multidisciplinary team and delegate a task for each and every one. Everyone knows their task, and the things like Dr. Edberg was talking about, like that one provider would be performing in other clinics would be performed by a number of providers. Also, the other things that help is like when the patients come in for initial visit, and this would apply to even patients in primary care. Like if during the first visit or the first few visits, we take a very detailed history of the patient and enlist everything that the patient has somewhere in the note, which anyone can find easily. It becomes very easy to lead the conversation from the second, third, and fourth time, because we'd just be talking about the changes that have happened to the patient's conditions that are already enlisted there, basically. So that streamlines a lot of things as well. So I would say time, then the other factor would be delegation, having a multidisciplinary team, and streamlining your note and your process as well. Always help.
And if I can just state, I mean, I think also we as Jim was saying, in the end, most older adults are seeing family physicians that don't have extra training in geriatrics and are working within their time settings that they have. And it can still be done there, right? Like, I think you can take really good care of individuals that are older, even in a non-geriatric setting. And part of the way you can do that is to just really be upfront in the beginning about, what are we going to accomplish together today? And just setting the agenda quickly, right? Like, because otherwise you look at the chart and you've got 10 things on a problem list. And the tendency we have is just like, okay, I'm not really even going to look at the chief complaint they're coming in for, but I really need to make sure like their diabetes is under control today, right? But in the end, you really have to listen to the other side and to just say, all right, let's just talk about what's going to be really important for us to deal with today, and start. And that's the first part. Identify what their needs are, in the discussion that happens, and make sure we try our best to answer that in the time we have. But then the second piece is actually to be aware, and that's what geriatrics training teaches you, the things people don't want to talk about, even though it's in their head. Because there's so many stigmas and still quite a bit of ageism about what we think about older adults that many of them won't bring up certain issues. So sexuality and aging is not very easy for people to talk about unless they feel confident that their physician is going to allow them to raise that issue. even concerns about memory loss, without us prompting or asking, doesn't get answered. Or sometimes it's like incontinence, like the case that Yukesh was talking about, or where, somebody's on a medication and it's interrupting with their day-to-day activities and their joy. They won't talk about it automatically sometimes. And we just have to prompt on certain things we know people might be experiencing. It's really important for us to also say, a lot of people I work with that are older have these concerns too. Let's talk about them.
Yeah, I would echo what a lot of people have said. I'm fortunate in that I do home visits, for the most part of my practice. So if I want like an hour with the patient, I'm not under that same time crunch that I would be if I was in a clinic, which of course I understand is a great luxury. And I also do work with a team, as I mentioned. So oftentimes, like a lot of those, patients are on 18 medications, 5 different psychotropic medications, where we can have, pharmacy reach out to actually talk to them like about their medication list and about, polypharmacy and like all that kind of stuff, right? But in a clinic, yeah, I used to work on a clinic too, and it's important to sort of have those, top 2 or 3 items. It's important to also understand that you don't have to do everything in one visit, right? That patients can always come back, right? And even advanced directives and about goals of care and LST notes, life sustaining treatments, that can be its own visit because it's really complex in some patients, right? Like it's a much more involved conversation. And you can also have your MA and your nurse talk about vaccinations. You can, of course, have your social worker talk about advanced directives, right? So all these kinds of ways that you can make things easier. But I think I'm gonna also piggyback off what Raj said. In geriatrics, we're the expert in the room, right? So those things that maybe people who have not, had as much geriatrics exposure, have not seen as many geriatric patients, that they feel uncomfortable talking about, hey, look, you're having memory problems and you've had multiple accidents driving your car and you've been in the hospital every month and you're weaker now and you can't really do things for yourself. All these sorts of, very difficult conversations, like the elephant in the room, that other things like other people won't really touch on, or they don't feel that they have the actual training to. That's our wheelhouse, right? And so those are things that we should really be sort of picking up on, because our training is with the whole patient and the whole elder, which is not just one system or the other, right? So the whole person.
I find the question was really intriguing to me because the one thing that hospice patients in particular, but geriatric patients in general, don't have in some ways is a lot of time, right? So for me, I think it's all about the focus. Our lives are not a continuum, not a continual thread. That's not how we experience life. We experience life in moments. And so a visit, if you can get the focus right in a visit, that moment in time doesn't have to be long. It's just dependent on the focus.
So it sounds like what it really all comes back to is what matters most, really nailing down what is most important to that patient in that visit, and then kind of tackling that. So yeah, it sounds like a great sphere to practice patient-centered medicine. I really love that. I kind of wanted to circle back to the concept of ageism that Dr. Shah mentioned. I know that there's a lot of ageism in society, and I imagine that some of the patients also have some internalized ageism about having their own thoughts about growing older. How do you kind of help the patients get over that, or kind of combat that in greater society, would you say? I guess I'll ask Dr. Shah.
Yeah, well, maybe I'll start and then others can add to it. Yeah, I mean, I actually think every generation that I've seen, and I've only seen a little bit of the snippet, but most of the generation I've seen has been sort of the baby boom generation starting to go through. And honestly, that group of individuals has always changed sort of the norms about whatever stage in life they've been in, right? And now as they're entering into their 70s, 75s and 80s, they're changing what it means to be older, right? And I give them a lot of credit for that in many ways, right? And now it becomes then how do we help the rest of us to understand that same thing that they're feeling about themselves? We can do more things if we want to. We can engage more. We can be connected more with our communities. There's a couple of really nice movements that have been going on, I think, to try to break some of the ageism and some of the stigmas that go on in communities. And one of them is sort of the age-friendly community model that the AARP has been sponsoring and other groups, but it's really getting communities to think through, like, what are our opportunities to help older adults that are part of our community to stay involved. And I always tell people this because, takes care of our grandkids, our kids after us. It's our grandparents, right? There's an entire generation of benefit we get by older adults being around. And sometimes we don't give them credit for that, right? We always sometimes think about them as being very frail or very sick, and that happens to some people. We have to take care of the frail and sick. But I think in some ways we also have to understand that most older adults are quite vibrant, quite active, quite involved, and engaged, and want to be engaged in their communities and their families and their societies. And how do we keep helping them to be in those spaces over time? When it comes to dementia, there's a similar movement called dementia-friendly communities. We've been helping a group called Dementia Friendly Illinois to get national recognition for communities. And we have 33 communities that in the last 4 years have become nationally recognized as dementia-friendly, from not only like the downstate Illinois and small rural towns to very diverse urban areas. So I think there's a lot we can do, and actually urban planners are getting better at this concept of how do we design our environments to allow people to be able to be more interactive as they age over
time. I think it's a great question, Emmy. I would say, in my opinion, ageism can take multiple forms, right? So the first can be that a patient oftentimes thinks that's what's happening to them, which is actually pathological, is natural because of age, right? And oftentimes it's about memory, right? So it's a very common one. People oftentimes think, oh, I'm old. I'm supposed to be losing my memory. It's natural that I forget things a lot, that I can't manage my own finances, these things that are actually alarm signs, and they sort of say, well, it's aging. So I think it's important to really have a good history, right? Because oftentimes patients will not volunteer this information when it comes to their memory, especially like with women, when it comes to issues of incontinence, because I think that's natural. They will not actually volunteer this information, right? So that's another important point, is to be, I would say, really diligent about certain geriatric syndromes that we talk about, like in fellowships and in training, right? So these 3Ds, dementia, delirium, and depression, and about urine, and about stool, and about all these things. And the other aspect of ageism is that the elderly being denied appropriate interventions on the basis of their age, right? You will see at times someone who had an MI or a stroke, and they're not on aspirin or a statin, and the reason is, well, they're 80 or they're 85. Or the person who has AFib isn't being anticoagulated. Now, of course, if they're 85 and if it's the end of their life, and if they've had multiple GI bleeds, that's a different story. But in a relatively functional 85-year-old, the evidence leans very heavily towards anticoagulation. That is the right move, right? And so oftentimes patients are denied that because of age, right? So I think that takes in multiple forms, and it's a very good question.
I agree with Avinash and Raj on what they have said so far. One thing that all of us have to realize is that we are finally realizing that the social determinants of health play a very significant role in the overall health outcome of our patients. And the fact that we're acknowledging that, I think, is a great progress. Of all the social determinants, of all the isms that we have, I think ageism is one which is still not talked about much, and it's still very prevalent, basically. You can make a joke about ageism, about like, getting old and still get away with that. And I think we need to change the framework around it, basically. Like, if someone says, oh, I feel like I'm getting old, I have to come to you, those jokes are not good, basically, because they're stereotyping people of certain age, basically. We have to recognize our own internal biases and work on them. At the same time, we have to create, like Raj said, age-friendly healthcare systems where, we ensure that we train all the healthcare providers from the front desk to nurses to all the staff about being mindful of people and their abilities and their age, basically. Some of the things that are being talked about right now are things. One of the words that I really hate is the gray tsunami that we have coming of older people, and it is a very negative connotation to the achievement that we have had in improving the longevity for our people, which has happened through a lot of strides throughout the field of medicine, basically through screening, immunization, better, care of the patients, and to just use those words, I think would be not a very appropriate interpretation of what is happening. And we have to help patients, like Dr. Monta said, recognize their own internal biases about aging. Sometimes, especially in depression in older patients, oftentimes they do not complain of depression. They just say, oh, I'm getting old, so I'm feeling tired, I'm feeling more sleepy, and I'm losing appetite. That's just a part of aging. And we have to make sure that, we talk to the patients about that not being normal as well. I do remember one case where actually I was still a fellow, and I was in my Urogyne rotation. There was a lady, she had urinary incontinence. She had a very social life. Her whole social life, after she developed incontinence, was affected by it. She developed depression. She was finally treated for it by the Urogyne, and the problem actually resolved. Her depression improved. She was so much touched by it that she actually wrote a poem to the Urogyne provider, and, they brought it to the clinic that day. And PHQ-9 improving, depression improving, and so those things are possible as well.
Dr. Orgain, I think I saw your hand raised. Yeah.
I did, and I apologize. I joined late, so if this is redundant, forgive me. I wanted to piggyback on what Dr. Shah said in regards to the communities. There, there are some cultural changes where it was an absolutely standard where families would live together. All age groups would live together. Particularly in the African American community, that has changed to a significant degree in the urban environment. And so there are facilities here in Chicago where they are developing that intergenerational living because they recognize the value of interacting with elders and seniors. And so you don't have to have a village, you can do it in a building, in a multi-level building, if the youth are amenable to that in regards to cooking and caring and all of that in that kind of community. One reason I'm late is I was also listening to public radio, and of course, they're talking about Biden and Trump. And the reality is that Trump is 78 and Biden is 81. Help me with that 3-year difference in regards to what the issue is in ageism. And so I just wanted to maybe add that because I'm that age. So
Yeah, one thing if I could change as we're nearing the end of our presentation, I try to bring this as I talk with medical students and other health professionals in their training programs. is, unfortunately, our training sort of biases also people about how they think about aging. Because where do you do most of your training with older adults is in the hospital setting. And there, who are you seeing, right? Are usually the frailest, the sickest, the ones on the most medications. We need to see and learn from them. But if that's all we see, we forget that like 95% of people over age 65 are living in their homes, independent in their communities, acting like their grandparents, like we forget that. And then that biases us in sort of our views of sort of what happens in aging. And I just wish there's more opportunities that people can see older adults coming to primary care offices, like actual practices in their sort of, family medicine or primary care rotations that they're doing. Because you just get a very different view of sort of the percentages of people in these different categories. When you're in the hospital, you think pretty much everybody's like in a nursing home, right? When the case is not, that's what's happening in the world out there. We have to kind of adjust those things too, if we had a chance. And I would definitely recommend like any student, resident, whatever it is, right? Like if you aren't sure about what you're seeing in aging as a representative of what it should be, find those rotations to meet people where they're actually at.
Yeah, one thing I would add, Emmy, is a lot of the time I find that where I'm combating ageism is within the family itself. And this kind of goes back to what I mentioned at the beginning. The part that I really enjoy is helping my patients maintain their own agency over their own decisions, because you'll have a well-meaning family who will say, I want to take care of mom, I want to take care of dad, I don't want them to have to do anything. And really what you want to feel for your whole life, whatever age you are, is that your life is meaningful and useful and you're doing something fulfilling and worthwhile. And when your well-meaning children start taking away those things that you enjoy doing, it does more harm than good. And, I can't tell you how many times I've had this conversation where they'll say, well, I'm mom's POA and I want whatever. And, to have to explain, well, she can still make you that doesn't kick in, just because you're the POA. She's making her own decisions and you've got to respect that. So I do think that there's a lot of ways that we can help people to rethink what it means to get older.
We have many philosophical wake-up calls in our life. And one of them is when you receive your first AARP card in the mail and you realize, whoa, this is happening. So we do have some checks and balances on our ageism attitudes.
Yeah, that's at like 50, Jim. I don't understand that. I mean, it's like my kids tell me I'm like way over the hill, right? But it's just like when you got that AARP card at 50, you're like, oh my, what's going on?
I just think it's a cool little reminder.
Yeah,
right. It's there's something going on there that's deeper than just that little card.
Thank you all so much for. Oh, sorry, Dr. Montha.
Sorry, I just wanted to just mention, one little thing quickly as a piggyback of what Raj said. One of my colleagues asked the students usually when they come in for the rotation, what percentage of the elderly are in nursing homes? Right, and the answer is like 2%. Okay, but then the students say 30, 40, 50, because everyone thinks that the number is very high. So I just wanted to just sort of emphasize that. Yeah.
I have a question. This is a little bit unrelated, but we're kind of getting to the end of our panel discussion here. So this is a question that I have as I'm considering, what specialty to go into, and I'm really interested in geriatrics. And I was wondering, what do you all think the outlook of the field of geriatrics is as our elderly population keeps growing? I know that there's a big demand for geriatricians, but how do you see those spots being filled, and what do you think are some draws to the field that medical students or pre-med students should know about?
Emmy, the field's wide open, absolutely wide open. And you look at the panelists today, and what you see are people that are accomplished, happy in their careers, doing work that they believe in. That's what you want to strive for.
Yeah, I definitely find geriatrics has been a great way of framing and learning over time how to become a better physician and how to become a better member in a community. And it's been so rewarding in many ways, right? So I think there will always be room to have more individuals trained in geriatrics. And I hope that, you know, we will never have enough that it's going to be parity to the number of older adults we have in the United States. But we do need people who go through that extra training, who can then be the teachers for everybody else, right? And you don't only teach each family as they come through, as Deb was saying, right? Like that's part of our responsibilities, teaching the patient in front of us, teaching the family. But you really start teaching the community, and you start teaching other of your peers about some of these practices that can make people's lives better. And enriched, and I think that's always the most exciting thing I found about being involved in geriatrics. And I remember getting some of those messages when I was thinking about geriatrics too, like, what, why would you do an extra year of training, you know, in that, you know, you're smart, you know, you should have done something else, right? But in the end, you have to be super smart to be a, you know, geriatrician, because you have to know these kind of subtle syndromes that are going on in the background, where there's no easy blood test or no easy imaging study that's going to get there. But you work, you know, in learning with your patients, and you build these like really wonderful relationships over time. And I would just always recommend it for people to think about if they have an affinity towards working with older adults, to think about geriatrics.
And I would say that a person can do anything with a geriatric training, right? I mean, we've had, you know, graduates like of our fellowship gone to be hospitalists. And at first that's a little bit of a confusing thing, but if you think about it, they understand discharges, they understand safe discharges, they understand, you know, goals of care conversations, right? They understand delirium. They can actually sort of, you know, spot it, and hopefully, of course, as we all know, intervening early to prevent it, right? So they understand all these things, right? We've had them, you know, go to be outpatient geriatricians, and be nursing home doctors, and be medical directors, right? I mean, they can do anything, and the outlook is bright, because of course, as we all know, America's aging, right? So, you know, we're going to have people living into their 90s and even hundreds, right? That's actually going to be common, right? So it's an incredible time in the world, right? We've never had this many people live this long, right? So it's actually an incredible opportunity.
I agree with what Nash just said. The one thing that I would like to add, I mean, for me, a younger provider coming in geriatrics, is that I see it as the new frontier actually in medicine, like cardiovascular disease, cancers, you know, we are making really great strides in them basically. So people are living with a lot of conditions that would have been terminal previously. The things that again, we don't have really great answers for. Most of them are in geriatrics right now, basically. Like some of the things, for example, delirium. You know, the concept of delirium, we knew about it from time of Hippocrates itself. Basically, apparently they had like about 30 words to describe delirium. Now we have a definition for that, and it just happened in our lifetime. Like, you know, frailty. We're developing a structural concept for frailty. Sarcopenia, we don't know why sarcopenia happens in people as we age. And I'm not just talking about a subset of population. It happens to all of us, basically. And this is something so uniquely human, but we don't know why that happens. Why does osteoporosis happen? So I think the more we know about this, the more it'll help us in our own life, the more we can help people, and also we can maintain functionality, which has been a key challenge right now. People are living longer. Maintaining functionality has been hard, but we can we can possibly have answers for those as well. So I would imagine, like, if some of the younger med students and residents, they go into research or they go into academic practice with some research and some practice, I mean, who knows, they might win the Nobel Prize for discovering an answer to these questions. So it's a field that has limitless potential, I would say.
I know that, I mean, to end is just why geriatrics is so super cool right now, because all my friends that were oncologists and cardiologists are now trying to label themselves as gero-oncologist and cardiologist. So when they add that gero, right, it means that this is meaningful, right, even in their careers. And we were there first. So yeah, definitely geriatrics is the way to go.
And my last question to all of you is, how would you describe your work-life balance? And maybe I can have Dr. Edberg kind of answer this first, as the Chief Wellness Officer. How do you make sure that your well-being is also managed?
Yeah, I think it is absolutely doable. I feel very strongly that if you have strong support at home, it helps you lean into your career. Likewise, if you have strong support in your professional environment, it allows you to have life at home. And I feel very strongly that, just being transparent about what's going on. We all go through arcs in our professional career and our personal lives. And sometimes there's a pull to one or the other. And if you have great partners where you work, everybody goes through it. And so when I have to kind of step back from work a little bit, I've got folks who support me there. When I need to step into work a little bit, I've got support at home. And so it's all 100% manageable. You just have to make sure that you've got the right people walking the journey with you.
Would anyone else like to comment on their work-life balance?
I think, sure, as a hospice physician, I mean, hospice doesn't take place only 9 to 5. So there are certainly, emergencies in the night. Last night I was up quite a bit of the night. So there are things that take your time. But in general, definitely have work-life balance, have colleagues that believe in that, have an entire organization with Vitas and especially the people that I work with here in South Chicago who are clear about who they are and how to find that type of balance so it can be found.
Yeah, and I think there's nothing wrong you have to also learn. You learn a lot from older adults by going with them on their journey and their experiences that help you as you kind of develop. I do find that there's these needs, though. You build relationships with people, especially like when I was the main medical director. I mean, I would follow patients sometimes for 15 years, 20 years, right? As they progress from a very early stage in dementia to finally at the terminal stage and then death. And like with anything, I think you become connected with other people in the world around you, and you also have to take the time to go through the process of reflecting that life and that experience that you had, and being part of the celebration of those lives too. And so that's really important for us to continue to have to also learn, and I think in most programs now they're trying to add features of that in training where you reflect on those pieces of having to watch people you care for also go through the dying process, and then how do you work on understanding that in your own experience and feel supported?
I'd like to add that you need to continue to do the things that you enjoy. I've heard much of it is related to medicine. Let's go outside of medicine and make sure that that you continue to enjoy yourself. You enjoy your family. You celebrate the holidays. You continue with whatever craft you have, that other skill set. If you knit, knit. If you bowl, bowl. If if you play basketball, do that. And make sure that you include that in your schedule. It's important because you'll forget how to dance if you don't do it.
Absolutely, and having a team, of people who are compassionate around you helps. In order to practice geriatrics, you need a lot of compassion, and most of the times, our team members that they are there to take care of each other as well, basically, and just that kind of environment helps, maintain your work-life balance as well as to prevent burnout.
I think there was a survey recently, and I actually mentioned this one in the first podcast, in the first talk, but I think geriatricians actually had the second highest job satisfaction of any field of medicine. And I think that the reason is because is that to us, like, our work matters, right? And so that's such a huge, like, part of feeling fulfilled at work is that we actually do something that we think is meaningful, right? And that, it actually makes an impact, like, in people's lives. And of course, we all have the, rough day. There are patients who we think about, gosh, like, I wish something else could have gone differently with that patient. Just to let you know, we all have those feelings, and still, right? Those always persist throughout our careers. But then there's just that interaction that we feel like was actually very meaningful, right? And someone who's, very thankful, and we sort of, guide them through something difficult, or they actually got some more time with their grandkids, and they're aren't in the hospital, right? And so those kind of interactions sort of ground us, right? And it helps out a lot. And for me too, I mean, I'm still relatively young in my career, but I enjoy the idea that I'm going to sort of, pass something on, right? Whether that's teaching, whether that's, mentoring, talking to other people, students, residents, being like, hey, here's, what I thought, like, at this point, here's, what I see right now, right? Sort of guiding others through that, same career choice. So.
One other thing, Emmy, is that during one's career, as you look, people will say, "Oh, I've accrued all of this leave time." So that means, and I've not missed a day at work. So that means that you aren't doing your work-life balance if you don't use those days. All right. So be sure to use that vacation. Ensure that you take that vacation.
Thank you, Dr. Orgain. I definitely will take that vacation. And thank you to everyone on the panel tonight. Thank you so much for such a great discussion. I learned a lot from a med student perspective as someone who is planning on going into geriatrics, kind of getting my foot into the door of this field. But I am sure that everyone on this call tonight, regardless of their training level, learned something new. So thank you all so much. At this point, I will hand it over to Ginny so she can make some final announcements and take it away, Ginny.
Thank you so much, Emmy, and thank you to all of our guest panelists from the geriatrics group. Just a couple of quick things to tell you about that are related to our topic tonight, and some things going on with IAFP. First, Dr. Orgain actually brought this to my attention earlier this week, an upcoming discussion on the future of end-of-life care, specifically in regards to the Black community as part of Black History Month. So this will be, everything I talk about will be in the follow-up email that's going to all of our registrants and our attendees. And again, this video will be posted. So if you knew someone who would have loved to have seen this, make sure you share it with them. The information will all be there. And then Dr. Shaw, our expert on the dementia-friendly primary care clinic, he's doing our next brain trust webinar. This one does meet the state of Illinois CME requirements. That's coming up next week as well, free for all attendees. So if you're in practice or you're going to be practicing someday, this is wonderful information. And we thank Dr. Shaw so much for his leadership on our Brain Trust program, which we've talked about. There is actually an open house, a virtual open house coming up on the VA for MDs and DOs. So this is another great opportunity to learn more about that specific career path and ask questions. And then some other opportunities for your calendar from IAFP. We are doing our Essential Evidence Update CME conference live in Naperville. It's a great one-day rapid fire CME topics on primary care's most pressing issues of the day. It's in person and registration's open. And our annual White Sox game. This is our most fun public event of the summer. And I know some of you on this webinar have been to it in the past. We have a date and we have the online website for purchasing tickets. So you can get those whenever you're ready. Check your calendar. It's always a lot of fun. And I think this will be our 17th year doing this annual fundraiser. And then Family Medicine Midwest is our annual conference that brings all the Midwest together, all the experts in all things primary care and family medicine. It'll be in Madison, Wisconsin this year. Call for abstracts will be open, I believe, by the end of this month. So if you've got something you've been presenting or been working on, get it up to date and get ready to submit it. And then you're going to get this in your follow-up. You'll get not only the link to 5 simple questions about tonight's webinar to give us your feedback, but you can also post a Google review. Believe it or not, that helps the Academy so that others can find us, whether it's people who should be members or would like to partner with us. So we appreciate that. So thank you so much for joining us. Thank you to all of our panelists. And look for an email later tonight with links to all the resources we talked about, and the recording will be posted again soon. Thank you so much to everyone. Have a wonderful evening and take good care of yourselves.